So let's discuss a very important condition known as scleroderma. So scleroderma is basically a multi-systemic connective tissue disorder in which multiple organs of the body is involved, including our skin. So what happens in the skin of a patient of scleroderma? We find there is thickening and hardening of the skin, and this occurs because of the collagen deposition in the dermis of the skin. So here we can see a lot of collagen is deposited in the skin of a patient of scleroderma, and the skin become very tight and hardening of the skin we find. So what are the facial features of a patient of scleroderma? You will find there is loss of facial expression in the patient of scleroderma. Their skin become very tight, thick, and the loss of facial expression give the mask-like faces to the patient of scleroderma. We find the pigmented lesion on the face and depigmented lesion also. Their nose is very sharp and pinched up nose, and they are having dilated vessel on the face, around the mouth, and around the lips. These are called telangiectasia. And you will find they have difficulty in opening the mouth, which is called the microstomia. And this appearance of microstomia also given the name as fish mouth appearance, tobacco pouch appearance, or crow feet appearance of the mouth. So as we said that there is loss of facial expression in scleroderma. There are some other conditions which you find marked faces. These include your Parkinson disease, scleroderma, as we know, hypothyroidism, bilateral upper motor neuron facial palsy. Even in depression, myasthenia gravis, pseudobulbar palsy, and dementia, you find the marked faces. They have loss of facial expression. Now we'll see what are the types of systemic sclerosis. We have the systemic scleroderma and localized scleroderma. Systemic sclerosis or systemic scleroderma is a multi-system disorder in which multiple organs of the bodies are involved. These include our skin, liver, kidney, heart, lung, musculoskeletal system, even our vasculature and GIT system is involved in systemic sclerosis. While there is one more condition in which only systemic features are there, but there is no skin involvement. No skin involvement, only systemic involvement is there, and this condition is called scleroderma, sign scleroderma. Now let's see the types of systemic sclerosis. We have two types of systemic sclerosis. We have the limited cutaneous, there is limited skin involvement. Then we have diffuse cutaneous, whole skin is involved. The most common out of this is 70% cases we find the limited cutaneous scleroderma, while 30% cases we find the diffuse cutaneous scleroderma. Limited cutaneous scleroderma is also called the Clast syndrome. In limited cutaneous scleroderma, you find the skin involvement is just below the knee and below the elbow, and the face is always involved in limited cutaneous. While in the diffuse cutaneous variety, here initially the fingers are involved, then followed by trunk and face, and gradually the whole body is involved in diffuse cutaneous systemic sclerosis. Now, when the patient presents, when we will suspect that this patient might be having the systemic sclerosis or scleroderma. Usually these are middle-aged female presents to us, and when we try to look the pallor in their eyes and we try to retract the lower eyelid, first of all, there is difficulty in retracting the lower eyelid, and you find you will not be able to expose the lower palpebral conjunctiva completely. So as you are going to see the pallor, you will suspect that this is difficulty in getting in retracting the lower eyelid, that this might be a case of scleroderma. So there are stages of scleroderma. Initially there occurs the edema of the skin, then later on the skin becomes thickened, indurated, and later on the skin undergoes atrophy. So these patients usually presents as Raynaud's phenomena. They show the Raynaud's phenomenon, and what happens is that in their hand, when they are exposed to cold weather, their skin turns initially white because of the vasospasm, and then it becomes blue because of the sluggish or slow blood flow in the hand, and later on because of the hyperemia, their skin turns red. So initially blue, then initially white, then blue, then red. These are exposure to cold. This is Raynaud's phenomenon seen in scleroderma. Also, you will find their hand involvement is bilaterally symmetrical, and you will find the swelling and stiffness of the hand. You will find the swelling and stiffness in the hand. You will find the skin of the hand is very tight, firm, and thick, and there is difficulty in extending the fingers and flexing the fingers. Also, you will find the dilated vessels on the hand, which are called as the telangiectasia. And also, when you try to pinch the skin of the hand, there is difficulty in pinching the skin, and difficulty because the skin is adherent to the subcutaneous tissue, so difficulty in retracting the skin of the hand in a patient of scleroderma. You will also find there are pigmented and depigmented lesions on the hand, which is given the name as salt pepper skin. Also, you will find the multiple calcium deposits on the skin, and this is called calcinosis cutis. In the hand, you will also find the pseudoclobing, which occurs because of the resorption of the terminal phalanx. You will also find the gangrenes, infarcts, and ulcers on the fingertips. And on doing the nail fold microscopy, you will find the dilated nail fold capillary loops on the hand. And even their pulp of the tip of the fingers undergo atrophy. There you will find the pulp atrophy, and their fingers become mutilated and deformed toes you will find. Here I want to tell you the other causes of deformed toes. We have the other condition include leprosy, scleroderma we know, even Burgess disease, frostbite, diabetic foot, vasculitis, and antiphospholipid syndrome causes your deformed toes and fingers also. Now when we will see the respiratory system involvement in systemic sclerosis. When the respiratory system is involved, the morbidity and mortality of systemic sclerosis increases. You will find because of dysphagia, they are prone for aspiration pneumonia. They usually have interstitial lung disease, and you will find the honeycombing on chest X-ray. You will also see there is pleurisy, there is increased risk of alveolar neoplasms. Even in 10% to 15% cases, you find the pulmonary artery hypertension. And in later stages, you will also find the cor pulmonale. Now about the cardiovascular system involvement in systemic sclerosis, these include your pericarditis, heart blocks, arrhythmias, restrictive cardiomyopathies, which occurs because of the myocardial fibrosis. So this is about the cardiovascular involvement in systemic sclerosis. About the gastrointestinal tract involvement in patients of systemic sclerosis. So what happens in systemic sclerosis, the gastrointestinal tract undergo atony, and this atony and dilatation is especially seen in the distal two-thirds of the esophagus. And because of the atonic esophagus, when these patients swallow food, they are unable to swallow it properly, and that contributes to dysphagia. Because of the atony and dilatation of the esophagus, this leads to the dysphagia, and this dysphagia occurs especially to the solid food in these patients. Also, some patients complain of regurgitation of food back into the esophagus, and this contributes to the inflammation in the esophagus, and this is called reflux esophagitis. And this reflux esophagitis lead to the symptoms of heartburn in these patients. Also, there is formation of vascular ectasia in the antrum of the stomach, and then we see with endoscopy these vascular ectasia, they are specially given the name as watermelon stomach, and these vascular ectasia sometimes bleed again and again. This leads to the recurrent occult gastrointestinal bleeding in patients of systemic sclerosis. Also, because the intestinal tract is atonic, and this atonic intestinal tract leads to the delayed gastric emptying in patients of systemic sclerosis. Because of the delayed gastric emptying, this contributes to the stasis, and bacteria start growing, and this leads to the bacterial overgrowth in the intestine, and that further leads to the malabsorption in these patients of systemic sclerosis. Now let's see the musculoskeletal manifestation in systemic sclerosis. As we know, there is a lot of inflammation in the joints of patients of systemic sclerosis, and this inflammation is symmetrically seen in both the hands, and we say this is bilateral symmetrical polyarthritis is seen in these patients. Also, because of lot of collagen deposition in the hands, this leads to the restriction of the joint movements, and there is difficulty in flexing and extending the fingers in patients of systemic sclerosis. Also, because of the collagen deposition around the wrist, this contribute to the carpal tunnel syndrome in these patients of systemic sclerosis. Also, there occurs the inflammation especially around the joints. In the tendon sheets, you will find the leathery crepitations, and these leathery crepitations can be palpated over the tendon sheets in patients of systemic sclerosis. Also, you will find there is resorption of the terminal phalanx. There is resorption of the terminal phalanx, and because of the resorption of the terminal phalanx, this leads to the pseudoglobin in the patients of systemic sclerosis. Also, you will find they will be having difficulty in combing and difficulty in getting up from sitting position, and this is the manifestation of the proximal muscle weakness in these patients of systemic sclerosis. Now we will talk about the kidney involvement in systemic sclerosis. So what happens? Because of the kidney involvement, their blood pressure rises, and this is called hypertension in these patients. Also, there is loss of proteins in the urine. This is called proteinuria, and this proteinuria in systemic sclerosis is non-progressive proteinuria. Also, there occurs the obstruction in the cortical renal arteries. This is called the obstructive vasculopathy, and because of obstructive vasculopathy, they are prone for scleroderma renal crisis, and it is the major cause of death in patients of systemic sclerosis. Now we will see how we will assess the severity of systemic sclerosis. So what we have to do, we have to insert the hand, we have to insert the finger side by side. A normal person can insert 4 fingers inside the mouth without any problem. But if a patient is having systemic sclerosis, they can, if they are able to insert only 3 fingers inside the mouth, this is grade 1 severity of systemic sclerosis. And if only 1 finger is inserted, which is grade 3 systemic sclerosis. What are the drugs that cause scleroderma like lesions? These includes the drugs like vinyl chloride, the drugs like bleomycin, pentazocine, aromatic hydrocarbons. Now we'll see how we will diagnose a case of systemic sclerosis. We will do a blood test where we will find the anti-nuclear antibodies. We have 2 types of anti-nuclear antibodies. We have the anti-topoisomerase 1 antibody and anti-centromere antibody. Anti-topoisomerase antibody is also called anti-scleroderma 70, and this is seen in diffuse cutaneous systemic sclerosis. An anti-centromere antibody is seen in limited cutaneous systemic sclerosis. Also, you will see that rheumatoid factor is positive in systemic sclerosis in 30% of the cases. You can also do the chest x-ray, and you can see the cardiomegaly in these patients. Also, you can do the x-ray hand, where you will find the acroosteolysis and calcinosis because of the calcium deposits in the hands of the systemic sclerosis patients. You can also do the barium swallow to study the esophageal motility disorders. You can also do the CT scan of the chest for detecting the interstitial lung disease. One more condition is mixed connective tissue disorder. So what happens? It is basically the combination of multiple connective tissue diseases together in a single patient, and these diseases like systemic lupus erythematosus, scleroderma, polymyositis, and rheumatoid arthritis, you will find their combination in a single patient. That is called mixed connective tissue disease. And for diagnosing the mixed connective tissue disease, a test, we will find a high titer of the antibody, that is the ribonuclear protein antibody, UIRNP antibody, is seen in these patients of mixed connective tissue disease. Now we will see what are the treatment modalities available for systemic sclerosis. We have the drugs like D-penicillamines. What these drugs do, they basically decrease the collagen cross linkage, since collagen is important culprit in systemic sclerosis, and this D-penicillamine reduces the collagen cross link in these patients. We can also use the drug like colchicine. So what does colchicine do? It will inhibit the conversion of pro-collagen to collagen. So collagen is not formed, so it is unable to get deposited in the tissues. Then we can also treat the reflux esophagitis with drugs like proton pump inhibitor and prokinetics. Also, these patients have a lot of muscle pain and that causes myositis, and to relieve the pain in the muscle we can give the drugs like glucocorticoids. Also, they have articular symptoms around the joint. They have the articular symptoms, and to relieve their symptom we will give the drugs like non-steroidal anti-inflammatory drugs. Also, as we know, in their lung they suffer from interstitial lung disease, and to treat the interstitial lung disease we give the drugs like glucocorticoids and immunosuppressants. Also, since there is risk of respiratory tract infections in patients of systemic sclerosis, we can try antibiotics also. Also, the layer of the heart is the pericardium undergo inflammation in systemic sclerosis, and this is called pericarditis, and to treat the pericarditis we give the drugs like glucocorticoids. Since they are also hypertensive, to control their blood pressure we give the drugs like angiotensin convertase enzyme inhibitors. Since they also have risk of scleroderma renal crisis, and we know that scleroderma renal crisis is a medical emergency, and for treating this medical emergency we give the drug like angiotensin convertase enzyme inhibitions. These are the drugs are helpful in scleroderma renal crisis. And the new drugs available are interferon alpha, interferon gamma, and human recombinant relaxins. Other drugs are also available. These are immunosuppressive drugs like methotrexate, mycophenolate, mofetil, cyclosporine, and azathioprine. Besides the systemic sclerosis, we will also should be knowing about the other uses of colchicine. We use colchicine in acute gout and pseudo gout, also in primary biliary cirrhosis, also in amyloidosis, in psoriasis also, and myelofibrosis. So this is about the scleroderma.